Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Lauren Ballinger. Dr. Ballinger is a board-certified pediatric dentist who obtained her Doctor of Dental Surgery and certificate in pediatric dentistry from the University of Maryland School of Dentistry. After spending 15 years in her family's traditional pediatric dental practice, Lauren left to open her own practice, where she and her team are devoted to proper airway and dental wellness and true collaborative care. Lauren is also the co-founder of the Endeavor Foundation, which is an international foundation dedicated to evolving standard pediatric dental thinking towards addressing the root causes of preventable ailments, especially as they relate to breathing, sleep, nutrition, and inflammation. In this episode, Lauren shares her fascinating journey from traditional pediatric dentistry to one that focuses solely on patient wellness and, more specifically, pediatric airway health. We discuss the challenges of incorporating airway-focused care into a busy practice, how to properly communicate with both the parents and the patient to help get them on board and understand the care that you're recommending and providing, the importance of proper behavior management in the proactive orthodontic treatment of younger patients, the challenges associated with finding auxiliary medical and myofunctional therapy providers for our pediatric patients and their families, the life-changing impact that dentists can have on a child's health and well-being when they focus on establishing nasal breathing from a young age, and much, much more. If you are or are considering incorporating more airway-focused treatment into your practice, you do not want to miss this episode. It is a great discussion between two colleagues, which will dive deep into a lot of the challenges we face and also get into the why behind our passion for this topic. As always, please be sure to share the show with others who may benefit from this information. And if you feel the Doc Podcast has earned it, we would love to receive a 5-star review on Apple and Spotify. So without further ado, let's get on to today's episode with Dr. Lauren Ballinger. Enjoy the show, everybody. Welcome to the podcast, Lauren.
Hi, thank you. Thank you for having me, Mike.
Oh, you're very welcome. I'm excited to have you on the show. This has been a long time coming with a lot of interesting, strange, small world connections that we've both had with with one another through common friends. The first was Cheryl Weiss, who is a myofunctional therapist up in Saratoga, New York, up near where I used to practice. And Cheryl reached out to me, goodness, a couple of years ago. It was not long after I finished up my practice up there and asked if I knew of any kind of Airway-Aware orthos or pedos up in the greater Albany area. And I said, sadly, I don't really. There really aren't. It's just not up there something people have really embraced or accepted. Now, again, this was a couple of years ago. That may have changed. But I know when I was practicing up there, I certainly was not welcome with the way I was looking at treatment or thinking about treatment. I kind of became the black sheep of the orthodontic community by starting to treat earlier and take CBCTs, low-dose CBCTs routinely and work with ENTs and allergists, and didn't realize this network I'd established was so unique. And so when Cheryl reached out to me, I said, what do I do? And she said, I'm sending basically all my kids to this amazing pediatric dentist in Massachusetts, but it's in Massachusetts, and not everybody can head through the Berkshires, especially in the winter months up there.
Yeah,
I've done that drive being...
It's a little rural where I am. Beautiful, but rural.
Yeah. So it is beautiful. And taking that drive through the Berkshires many times and going back and forth to Yukon. And it's just, not everyone can make that trip. So she said, I really would like to find somebody here for some of these families that can't travel. And I said, I'm sorry, I just don't know of anybody who is. And so she had mentioned you, and she was raving about you and what you do and working with you. And then I have Loria Nahadis on my show. Yeah. And she starts telling me this story about this pediatric dental colleague that you guys went to residency together. Is that
residency together? Yeah.
She said you were really close, and she starts talking about this pediatric dentist who saw pictures and started asking some airway questions about Loria's daughter. And she's saying she's up in Massachusetts. And I'm like, wait a minute.
Sorry to put it together.
And then she says something about Lauren. I'm like, Lauren Ballinger? She's like, yes. How did you know? I'm like, oh my God. So anyway, it is such a small world. It's really, really crazy. But tell me about your story. How did you get to be the Dr. Lauren you are today? What has led you to this point? And you can take it back, even if you want to go back to pre-dental, before you went into dentistry. I'd love to hear more about how you got to where you are today.
Well, like I think a lot of people in Airway, the impetus was really my own children. I was practicing in a practice with my father and my uncle, who had a very well-established pediatric dental practice in Western Massachusetts. That's how I ended up here. I didn't plan to start here. I didn't even necessarily go into dentistry because my family was in dentistry. I thought I was going to be a lawyer to bell stats and everything. But when it really came down to thinking about what it was that I wanted to do, what I liked, working with my hands, it was sort of the obvious was right in front of me. So I always knew I wanted to be a pediatric dentist. I was living and I did my dental school and residency at the University of Maryland. And I had family both in Maryland and Massachusetts. And my husband and I were there. And I was in a great pediatric practice that had its own separate orthodontist. And kind of what's funny is that the only appliances I saw were based on if we were doing, it was same practice, but different, would be some of these appliances. And as a pediatric dentist, I'd be like, whoa, what are these things? They're terrible plaque traps, which going forward now, sometimes I hear from other dentists that children are being seen on recall. And that's something we have to communicate a little bit about. But yeah, it would be sometimes like, what's this expander? And now looking back, she was actually doing it not under 6, but she was a little bit earlier. But we decided to locate to the Berkshires because my father and uncle did have this really great practice. The Berkshires are a beautiful place to live, and it just seemed right. So we came here, and one of the first things my father said to me was, I hope you like orthodontics, because they had a practice that was about 50-50 early, which it was very unique for a pediatric dental practice in that they were doing the orthodontics.
And this is just your dad and his brother. Those are
and they were also very well respected in the area, but also a little bit of social pariahs as well with the local orthodontist, sort of like, why are you into our territory kind of thing. So when I moved there in 2009, or moved here, my biggest fear was, I don't really think I like ortho. And you hadn't really done any in Maryland. You were just observing. I did do Maryland. We did. We our first year was at, sharing a lot of the same classes with the orthodontic residents. We did that a lot. We had, I think, 1 day a week. I did not like it, but I was really focused on sort of being the Pied Piper of pediatric dentistry, really loving the restorative, really loving getting kids through, these early anxiety-provoking type of things, and also prevention. It was actually around those years in my residency that I believe that before age 1, or at least within 6 months before your first tooth, recommendation came down from the American Academy of Pediatric Dentistry and the American Pediatric, the AAP, American Association of Pediatrics. So during my residency, that was sort of a really big push of something that we could start to talk about. And I was very passionate about that. And when I was first starting practice in Maryland and in here, I'd be, sort of reaching out to a lot of general dentists about that, the way that we do now with Airway. So as soon as I joined the practice, I did a year-long little mini residency, on weekends, every other weekend, just basically learning straight wire orthodontics. Okay.
Now, were your dad and your uncle, were they doing a lot of early ortho, or were they just kind of doing comprehensive ortho?
Early. So they would do a lot of typical of what we think of phase 1, phase 2, right? Okay. But the phase 1 was like about 7.
Okay. Yep.
Right.
Got it.
Right. Yep. So phase 1 and phase 2. And they were very successful in that they were the only ones in the area, doing under 12. Right. So I learned, and I started doing cases. I started doing more. If we were expanding back then, we were using a quad helix. I used to actually pride myself on saying, and I don't really have shame of saying this now, because I think a lot of people might feel this way, that if they came in to see me for a consult, so I'm talking about 7, 8-year-olds, we were recommended to have an expander. And I would say, I can get all your teeth into your arch without using an expander. and feeling pretty good about that, because I think in some ways, especially if you're treating around 7 or 8, you probably can, right? So I was like, oh, you don't need that big bulky expander thing. Well, meanwhile, my children, I have a backstory with my son that starts at birth. And it was a terrible first year, terrible first 3 months, breastfeeding issues, terrible reflux, all these barium swallows to check for, thickened formula, aspirin, everything. And going back to the beginning, it's because he had tethered tissues. And I had him, it was my first year in residency. And even in residency, we weren't learning this. And it was just a really, really hard experience. Well, that led to, we were in Maryland at the time, and he had ear tubes, yada, yada, all that stuff. And then at 3, his ENT said, we're taking out his tonsils and adenoids. And I didn't know why, but I will tell you this. He was born, he's adorable, he's great now, but in every picture that you see of him, he's like this. Okay, like he couldn't breathe. He was born with tethered tissues and not being able to breathe well. And so all of this just stacked up on itself. So we got his tonsils and adenoids out at 3. Things improved, but there was still some lingering. I sort of talk about it as you have healthy children, but there's these little things that just don't seem right about their health. Nothing that the pediatrician would necessarily pick up on. Then I had my daughter about 2.5 years later. Her infancy was completely different. Everything was going well. We moved to Massachusetts. She had that perfect smile that looked like she had spaces between her teeth, but her face started changing in that her bite started getting deeper, getting some retrusion, some big time Bimax retrusion. And all of a sudden, her sleep became horrible, just horrible and noisy. So, as a mom, not just as a dentist, but as a mom, I'm starting to think about what's going on here. And then I'm sort of seeing my orthodontic patients, or just my general pediatric patients, just sort of giving me histories about tonsils and adenoids. So I'm at the Yankee Dental Conference. I don't know if you remember that, but it's New England.
Sure. Yeah.
Right?
Yep.
And there was a lecture I signed up that I don't remember what the title was, but it was something like Early Intervention Orthodontics and Airway. So I signed up.
Okay.
And it was a pivotal 3 hours of my life. And it was as if, I always say, a divine intervention or something. I felt like a lightning bolt had hit me. The whole, it was only 3 hours, but, it started with showing children's faces, talking about, here's their school report, here's the report from the mom, here's the report from the school counselor, and really diving into that and saying, look at these faces. Do these children look vibrant? Do they look healthy? Do they look like they're having a good time in life, right? And I'm seeing that, and I'm seeing every child patient that I see coming into my practice that we were getting used to, we see as normal, but it's just because so many children look at that. And then they started to get into tonsils, adenoids, frenums, and then I was like, these are my children. These are my children. And what is really unique about that, there's so many things that you hear in your lifetime that really inspire you, whether it's the climate change, whether it's some sort of charity, but there's a lot of things that the only way you can make an impact is by maybe writing a check, right? But I'm sitting there thinking, holy cow, I can do this starting tomorrow with my own hands, right? There's very few things that fall in your lap that you start to feel very passionate about that you can actually do something about. So I walked out of that lecture and I found my husband, who's also a general dentist, and I found my father, my uncle, and I was so excited. I said, this changes everything. I am never going to practice the same way. All this stuff about bringing kids to the OR, gingivitis, everything, it's so much bigger than this. And they all kind of looked at me with, owl blinkers and said, what? Does that mean you're not doing sealants anymore? I said, no, guys, this is bigger than that. Anyway, that started me on my journey. And I just started really digging in. I went to work that Monday. Some people that might be hearing this and are in the beginning of their airway journey, you start to realize that a lot of the things that you're doing are not airway protective. Mm-hmm. And I remember seeing one of my first patients that Monday morning who I had in class 2 elastics for, more of an overbite kind of situation. Mm-hmm. And I remember saying, we have to stop using these elastics. And they said, why? And I said, because they're bad for you. Well, what are we going to do? I said, I don't know yet. But I feel as if I need to tell you that, they're going against the grain here, right? We're retracting.
And what was the premise of that, of the class 2 elastics causing harm?
The retractive dentistry, instead of, some of the basic principles that I see about airway-focused dentistry is that knowing that the jaws are the bony borders of both the nasal airway and the posterior airway, right? Mm-hmm. So when we're talking about the posterior airway, anything that's coming forward is going to make that airway volume bigger, or it's protective. Let's just say it that way. Mm-hmm. Anything where we're retracting has the potential of making it smaller, right? Not to mention that retractive dentistry also is, jamming the jaw joints. It's just going against the grain of growth, right? We know we want to grow forward. So like in overjet, right? Mm-hmm. You have 2 options. The option that I knew about was retracting the teeth back. Mm-hmm. And if we're talking about airway protective dentistry, knowing that the bony borders of the jaws are also the borders of the airway, the nose being the maxilla and the position of the maxilla and the mandible in relation to the posterior pharynx. Not to mention that, I got into more, retractive dentistry, also jamming your jaw joints back in there. It just goes against the grain of how we want to grow. It also reduces oral volume. Right.
Now, how did you know at that point that you were retracting the upper? No, meaning from class 2 elastics biomechanically. How did you know that class 2 elastic? How did you know the differential force magnitudes delivered to the maxilla versus the mandible, and the impact it have on the maxillary retraction versus, because some people will hear this and say, when you're doing that, yeah, but you're also bringing the mandible forward. You're not pushing the mandible back. I mean, for people who don't know, and there's lay people listening to the show too, a class 2 elastic is using the upper kind of as the anchor to help the lower come forward. So you hook it further anteriorly on the top and then further posteriorly on the bottom. And there are a lot of different ways of doing it. So I just want to be careful to paint it with too broad of a brush, because as an orthodontist, I've treated many, tens of thousands of cases. And yes, if you do class 2 elastics the wrong way or at the wrong time or with the wrong wires, or you don't protect it with certain disocclusion, types of disocclusion, you can cause, or if you pull up her teeth and then use the class 2 elastics to retract the top teeth, certainly. But I just want to be clear. There's no evidence that I'm aware of from a orthodontic standpoint that you having a retrusive effect on the lower jaw or the TMJ with a class 2 elastic. Because it kind of sounded like it came out there. And I'm not saying it's how you meant it, but I just want to clarify that.
No, I mean more like I'm talking about how did I know that? Now that you're asking me I don't know. I think it was a combination probably of some of the training I got in residency, some of the mentoring I was getting. It was what I talked about, what I did, like I said, a mini residency with Lenny Caraprezza, who is a pediatric dentist who has taught a lot of orthodontics over the decades. I think, honestly, I probably learned it from working with my father and uncle, that if you have an overjet, you put on class 2 elastics. I didn't do it a lot, but I did do things like, if we had some spacing, to use Pletcher springs to kind of cinch it back. How did I know that it wasn't the right thing to do? I don't know. I think intuitively, when I started hearing this stuff about oral volume, it made so much sense to me intuitively, that to the point that sometimes I don't understand why it doesn't make sense to other people intuitively, if that makes sense.
I'm going to push back a little, because I think if it makes sense, you've got to be able to explain it.
Yeah.
And the explanation might be that you've seen it, or I have certain cases that it happens in, but I've used class 2 elastics in tons of cases where if you time it at the right age, that's a big part of this too. If you're going to be circumpubertal, if you're throwing class 2s on these young kids, you're going to get a lot more dental alveolar. But the literature is pretty clear that if you time it well, anything that you're going to do from a class 2 mechanic standpoint, you're probably going to get about 50% dental, 50% skeletal if you can time it well. So again, I get what you're saying. There's a dental component. It is not, the only way, I used to tell patients all the time, the only way if you have a class 2 with a retrognathic mandible, which is 85+% of class 2s, according to the McNamara study, and even 30% of class 2s are actually maxillary retrusive as well, which is I think the point you're making as well. Just because you're class 2 doesn't mean you have a protrusive maxilla. That's a huge myth in orthodontics.
Right.
You have to get beyond that. Biomechanically though, the only way you're going to literally have zero impact on the maxilla is to surgically move, if you don't use it as leverage, is to surgically move a mandible forward that distance, because it has to lever off of something. You could try to use some sort of extraoral appliance, but that can have side effects on pushing on the facial bones as well. So there are ways and certain compromises, but I agree with you that if you are using class 2 elastics to try to pull the upper back.
That was what I was trying to do.
Right. That's not what we want to try to do. If you're using them like what I did, actually as a kind of a little pearl out there for people, one a really cool trick when you use class 2 elastics, traditional orthodontists will straighten all the teeth. Actually, not traditional. They're teaching this in most orthodontic residencies to this day. Straighten all the teeth first. Okay. And then try to use heavy class 2 elastics to try to bring the lower jaw forward while you're in these big, heavy wires, like strong steel wires. It's still being taught today. So one really cool trick that I picked up a while back is you start when you first put the braces on. Let's say we're not talking early treatment now. We're talking like, kid first comes into you, right? You first see the patient, they're 11, 12 years old. They come in, first visit. What are we going to do?
Right.
What are we going to do? Right. They're like end on-ish class 2, maybe a little more. Again, it's rarely, if ever, a maxillary protrusive issue. It just almost doesn't happen. But so fine. What you can do is you design, and without geeking out too much on this, not getting technical pictures.
Tell me more, yeah.
But you can use bite ramps that create kind of like a twin block effect, right? Which lets them posture forward. And you use a very, very light class 2 elastic, like 2 ounce. And you use a short vector. A lot of people call these shorties. You don't go like upper canine to lower molar. You go literally like upper first bite to lower second bite.
So almost like a little reminder to...
You got it. It's like, right.
It's a little like reminder. Yes.
Exactly. So it's technically a class 2 vector. I'm giving air quotes around that. But it's not the traditional like heavy class 2 elastic that will and potentially can have a retrusive part on the upper because, it's an equal and opposite force. And yes, the mandible's freely movable. The maxilla is fixed to the skull. At the same time, you still are getting that force. It's a really nice way. And when you create those bite ramps, you guide them so that when they bite down, they're posturing that mandible into a protrusive class 1 position. And I love that word for it. It's a reminder that those class 2 elastics, that light, short class 2 vector, is just kind of telling them you got to go here. And I would always tell patients, and my assistants would tell patients when they get it, go with the bite. Go to where your teeth fit the best. Don't fight it. Don't try to fight your lower jaw back. Let the bands lightly
do their thing.
Yes. And so when you guide them forward, you get tremendous anterior posterior correction and I have the pre and post CBCTs, minimal, maxillary retrusion on that. Minimal, if any, unless they had protrusive incisors and you want them to come back a little because they're, at a bad angle and periodontally it's not healthy. So anyway, so I just want to clarify that.
That's a great tip that because now at this point, when I do have patients that are older to come to see me, it is so fun treating 6 and under because there's so much potential to get this growth on track.
And they're pliable. Mm-hmm.
Yes, pliable. And when you do see patients that are, in that mid-late mixed dentition, early dentition, it's a lot more challenging. And to be honest, I love hearing things like this because to me, those are the most challenging cases. Because they're not as pliable. You can't really grow them into what you want them to be is easily. And, sometimes with me, I will treat older kids only because, and I'm really honest with parents, only because everybody else is telling them something like they're going to extract premolars or they're going to do something that the parents really feel like they just don't want to do. So sometimes I become the default last hope. And as one of my mentors, I don't know if you know Bill Hang, said to me,
Yep, no, Bill.
I would take him to these cases years ago and being like, I can't do this. This is out of my, wheelhouse. And he would say, well, if it's not you, who's going to do it? Who's going to do it at least by not harming them? So even sometimes understanding with patients that for older patients, we may finish with overjet, right? But understanding why we're doing that. And there are some families that want that. And I do love hearing what you just said, because the more information I can get for those patients that are a little bit more difficult, the better. What I love to do, of course, is to see the under 6, because it's such this is what I like to say. Let's get the teeth out of it for a minute and talk about the faces of the quality of life.
And before you go there, 1 second, Lauren, just so I am working on a course to that point.
Oh,
I'm working on a course for adolescent class 2 correction. That's not retractive.
Yeah, because it's hard.
Yeah, it's so hard. And I did a ton of it in my practice. I really was very sensitive to the fact that I didn't want to be retracting. I rarely treated, I wasn't extracting upper bis to bring those teeth back to the traditional way orthodontists will do it, which is treating the wrong jaw. You're treating the...
Right, it's the wrong diagnosis.
It's the wrong diagnosis, right. Can you make the teeth fit? Sure. Our boards, I believe, I know when I took them, they had an upper bi extraction case. You needed an upper bi extraction case to show for your boards.
Yeah, they're beautifully.
Right, you can make the teeth look great. Right, but why was that the case? Now, without getting, again, too far down a rabbit hole on it, technically, if they lost primary teeth early and all the posterior teeth grew in mesially or anteriorly and blocked them out, and there's a premolar that's completely blocked out, that's a different story. If you have to remove that impacted tooth because everything grew forward, that's not retractive in that sense because it lost the arch length. So that there can be cases, but we're talking about a case where they have maybe, in this case, even decent space for the upper teeth. There may not even be much crowding, right? And they've got 8 to 10 millimeters of overjet. That is almost never a maxillary protrusive patient. So when you take that patient and you treat the upper or distalization appliances to drive all, which is the same thing as extraction, you're just saving the teeth. You're still treating to the same endpoint, whether you distalize the arch or extract the premolars. You're still treating to the same incisor point. It's not really any different. But from a VTO standpoint, but there are a lot of ways that I developed and worked on because I was very particular about getting ideal class 1 great results with my patients. I did not like leaving overjet. Now, to what you're saying, I would be happier with leaving overjet and not retracting the upper teeth than retracting the upper teeth just to get rid of the overjet.
It's a big compromise, but
it's a big compromise, right?
I agree with you. If and I also understand too that in orthodontics and physics, for every reaction, there's an opposite reaction. To be able to, when we're talking about sort of the non-growing patient, there's going to be some retry. So that's why I like to think of more like, how can you protect oral volume?
Yes.
How can you protect the airway?
Yeah.
As opposed to just sort of going in there without thinking and just being tooth focused, right? I agree with you with, unless you're doing surgery or have some sort of anchorage outside, you're always going to get some retraction. It just, it's the way it works. But how can we do it a little bit more protectively? And I also think
some people say herpes appliances, you'd never use them. I've heard people say that. And it's like, if you don't know how to use them, and you can get a tremendous headgear effect and you can have a retractive effect. If you know how to use them, how long to keep them in, how you advance them, it's very, very, very strategic and precise how you treat them. And just because it's it's just like with anything, whether it's an expander or a quad helix, or there's ways to use Invisalign or clear aligners. Like, you can do it one way and have it work really well, and you can do it another way and not work so well. And so, there's tricks. So I'm working on that course and building that, because it is something I think that
that is an area for us who are doing this, who don't have extensive we don't extensive orthodontic training. I mean, that's big time stuff, and it's important. And I'm so glad that you're doing that, because at the end of the day too, parents do want, not all, to have a cosmetic focus, but there is a cosmetic focus, and there is something to be said about having a nice balanced smile. You just have to be aware of the bones and the skin overlay to that smile, right?
Yes. It's not just about the teeth.
Right. It's not just about the teeth, which you were bringing up, that, boards, I'm not an orthodontist, but it sounds to me from what I heard, a lot of boards are, look at these models and these teeth. They're in a perfect class one without asking any other questions about
none. It's nothing about the patient, it's literally
the teeth.
I mean, it's the models on the table analogy. That's when I took my boards. That's what it was. I literally had to fly to Dallas with all my cases and protect everything. And they had to see these perfectly polished and trimmed models that were articulated beautifully, and, had polished them and all shiny, and they would set them on the table. And if your models had even an area that wasn't smoothed or polished to a pristine shine, like military belt buckle style or military shoes style, you're done. I mean, they would chastise you, because it was just like, how dare you bring this garbage in front of me? Never talking about the patient, never talking about the etiology of the crowding or the etiology of the malocclusion. It was all about how you took them from point A, which is where you first saw them, to point B. There was no phase 1, phase 2 cases. I think they did change that. Don't quote me on that, but I think they've added that you have to have one case, but that could just literally be a case where they presented to your office at 7 with a posterior crossbite, and you put an expander in, you fix the expander, you fix the crossbite, and then you go and do braces when they're an adolescent. So it wasn't like, there's no focus or discussion on the ABO still to this day about airway, about early proactive growth and treatment. It is still about reactively getting the teeth to be straight. And the last thing I'll say on that is not even in the context of where the soft tissues are, or where the tongue, the soft tissues, the tongue, the lips, the cheeks.
Exactly. And I think
that the airway.
When I do a lot of education with Mariana Evans.
Mariana's great. Yeah. Yep. She's on the show too.
I call her my Taylor Swift. Right. But, we have a study club that I'm part of. Anyone listening to this, her study club is amazing. It's every Tuesday. And it's really cool, because there's also some other orthodontists in there. And then there's some ortho-periodontists. And then there's also some ortho-prosthodontists. Okay.
Great group. Yeah.
It's a great group. And to sort of, even though I'm a pediatric dentist, here we were talking about deep bites. And, all the prosthodontists were like, it's the worst, right? Restoring a deep bite.
It's a nightmare for them. Yeah.
Yeah, it's a nightmare. So even understanding that helping it is so much about airway, but it's about so much more. It's just, it's all encompassing. And I think that if people really get down to it, like restorative dentists, and understanding what a nightmare that they're trying to deal with, right? As an adults, to rehabilitate them, kind of like, well, let's look back. Why? Like, why has this happened? Right. Yeah. And that's the big part it's been missing. And it's interesting, because I think dentists for a long time have had sort of a little chip on the shoulder, well, we're doctors too. Well, then we need to act like doctors too.
Right. This is our window. I love that you said that, because I say all the time, this is our window to be more, at least speaking to my orthodontic colleagues, but it applies to in the pediatric world or the general dental world. This is to be more than just tooth straighteners or tooth fixers, right? Or bite fixers. This is our window, our opportunity to treat the whole patient. We seem to embrace, when perio, I think I was kind of in dental school, it was in the 90s, when the whole cardiovascular association came about. Our profession, I feel like, really embraced that. Wait a minute, the oral microbiome can impact the heart. And we took a lot of pride in that. And I feel like now we're like, okay, the oral cavity volume and the mouth can affect every system in the body by the way we breathe. And we're like, don't really want to go there. What is that about?
I really don't know. I don't know. I think maybe subconsciously that when you really think about that, right? And you think about, and I know a lot of us have faced this. You have obviously faced this. I don't know when you were practicing how long if you ever had a little stint where you weren't thinking of the whole body or the soft tissue or oral body?
The first half of my career. Yeah.
Okay. So I think maybe when you get exposed to this and you get a little peek behind the curtain, it's kind of like, holy, I'll say cow, but something else. What does this mean? What have I been doing? And I went through this too. When you fully embrace it, you have to change everything in your practice.
It's
the
true.
way it runs, in
your team training, your scripting, right? Everything.
Because guess what? You have to start talking to patients. You have to start doing education. You can't just come in and run 4 columns where you're just, you need your whole team to be educated, from the person who answers the phone.
Yes. Every clinician has to be on board with
paradigm shift. And then of course, and I think this is changing a little bit because insurance is just getting so crazy that people are starting to realize that, insurance isn't covering much of anything, and it's such a high premium. I think dentistry in doing fee for service has been a little bit ahead of this, but I think that patients are starting to be a little bit more accepting of that because they're realizing that they're not getting the great deal. But a lot of times I hear in sort of these introductory classes that I've either sat in or I've been part of, the first hand to go up is, well, insurance doesn't cover this. You have got to just, first of all, okay, I'm going to give you a medical story, and this is exactly how it feels today if we don't talk to our patients about it. And by the way, I'm sure everybody listening knows that the ADA 2017 guideline says that we as dentists, every single dentist, are responsible for doing an airway screening and asking questions. Just like doing an oral cancer screening. It's like part of standardized practice. That's not happening either, because you know what? When you start asking the questions, all of a sudden, you can't just sit down and say to your hygienist, okay, it looks great, I'm out of here. You know what I mean? It just becomes a whole conversation.
And the AO white paper also, as much as I have problems with a lot of that white paper, it calls for orthodontists to screen every patient for airway.
Right. Well,
doesn't tell you how to do it, but it calls for it. So if any orthodontist is saying, well, the orthodontic, they literally call for us to screen every patient for airway. So the fact that we're not, what percentage would you say of first ortho and then maybe all dental providers are screening for airway, do you think, routinely?
I'm going to just take a stab. Do you know the number?
I don't know.
I would say, I'm going to sound really pessimistic here, but I'd say 10%.
Yeah, I'd go with you on that. Yeah, that might even be, I might even say that's optimistic.
Was that generous?
I was going to go 5 to 10. I just think, I know if I think of 10 orthodontists, can I find one of them in that group? I obviously know a lot more orthodontists that are doing this, but if I just were to take a random sample, it's not common. And when I say screening, I'm talking about PSQ or asking certain questions. Not just, do you have obstructive sleep? Have you ever been diagnosed with OSA? That's not screening.
Most people will say no. FYI, if you ask most mothers in sort of not in the most gentle, probative way, if their child is a mouth breather, 9 times out of 10, no.
Or snore. A lot of times, does your child snore? No.
And I don't know if Lori had told you this story, but I've heard her talk about this a lot too, that when I asked her about her child mouth breathing.
She did say it on the show.
First thing is not my kid. So we have to be very sensitive to that about people, that parents never want to think that anything is wrong with their child because it feels like a direct reflection of their parenting.
Of course.
Right.
Yep.
So, and we learned that as as pediatric dentists too, that how to help untangle those things and be able to give productive, preventive things. When you see a child with a mouthful of cavities, you do not look, if you want to get that child from here to here, right? You don't look at the mother and make an accusation.
Right.
Right. We have to find out.
So you get some of that training in your pedo residency.
That's all pedo.
Yeah, we don't. See, in ortho, we get none of that. And I've said that's one of the problems with ortho.
This is where we have to come together. This is what pediatric dentists know what to do. We know how to have very hard conversations in terms of where you are, what we have to do, and how can we prevent without turning off or scaring the parents that are caring for these children. right? And if the first thing that we see when we see a mouthful of early childhood caries is, what the hell have you been doing? Like, you're neglecting your child. That parent is gone. And we also think, too, coming from a place of love, I would say 99% of the population does things with their children because they think they're doing things that are good for them. Mm-hmm. Right? Mm-hmm. So there's not a parent ever that's putting their child to bed with a bottle of milk in a malicious way.
Right.
Right? It's because it's soothing, it's stopping the baby crying, they think the baby likes it, all these things, juice, everything. So it's not like, I'm just going to, poison my child. No. So we have to understand where they were and how we can help them coming forward. So going to mouth breathing, if you are trying to, and I found this out pretty quickly, and so did Loria. If you come back from a class, right? And so then you're just saying, ask the hygienist to just quickly ask them, are they snoring or mouth breathing? And the parents are just there thinking they're getting a prophy. They kind of look at you like, no, and why are you even asking?
Great point.
Right? So you really have to sort of get your team together, your thoughts together about how you can give this information in micro doses. Mm-hmm. Because now I'm in a position, which is great, where people are seeking me out for a very specific reason. And that's a lot more fun and easier. I didn't get to be here overnight than when you first are sort of having a panic attack because you have all this information. And even if you're like a associate in a practice and you feel like you don't have a lot of control about just then all of a sudden just starting to ask these questions, and it can feel very overwhelming sort of to the non-suspecting or non-knowledgeable parent. It can feel a little bit accusatory, and it can feel like, look guys, I just came here because I want my teeth cleaned, right? So you
go to the orthodontist, want your teeth straightened.
Right, and, exactly.
And to that is exactly why I say all the time that orthodontists aren't embracing this writ large, because we don't have that time built into our days and our schedules.
Absolutely.
We don't have time to.
Then you talk about production. What's that going to do?
Exactly. Your workflows, your production. And I ran a practice where I did this. I ran my own office for almost 20 years. I know the challenges therein. But I was always my own solo doc and my own boss. So I could make these changes. And I love that you brought up too, if you have, you work for a corporate, or you have a senior doc or a partner or whatever it is, and then you add, that's a challenge for all of us. Then you add in the orthodontic world, we're not trained on what you just said. Like, we're not trained for talking to the parents about how we're going to approach the child's malocclusion or maybe why they're that way. We're not trained in that. We're trained to look at it and try to figure out how we're going to get those teeth to line up nicely. That's literally what we're trained to do. So this is asking orthodontists, and I put this in a context to grant my orthodontic colleagues some grace. This is asking them, you said it, revamp their entire practice, essentially, right? Their workflows. They go from just constantly seeing patients, 75, 100 patients a day, turning that wheel, rewinding that clock, right? Open bay. Now you've got to have hard conversations in the consultation room. You have to train a team. Your TCs, who are trained by and large, I don't mean this negatively, I had TCs myself, they're trained to sell the case. I mean, that's really what your TC is doing. They're there to educate. I shouldn't say it all in that, because they are educating. They're telling them about the braces and all that, but they're trained to sell the treatment. The doctor comes in, tells them what's needed, and leaves. And the TC is to close the case, right? And go look no further than any orthodontic consultant who really focuses on the TC. They have workshops on it. It's big, right? Now you're asking the doctor to dig deeper into the diagnostics. And then, as you said beautifully, you were using the example in the pediatric realm, but in the orthodontic realm, now you found it. You said with the example of oral cancer screening, or with your hygienist detecting it. Now you're the orthodontist. Now you found a problem. What do you do now? How do you have that conversation? How do you even begin to, how many people
Right. So think of the opportunity of orthodontists and pediatric dentists coming together to share their knowledge.
I love it. Yes.
Okay. Like I did once, like when I was asked to, I was speaking at the Airway-Palooza, the very first one. And Lauren asked me to give the lecture that I had given, that she had heard at the AAPMD, which was all about this. But I said, you know what? I think I want to give a lecture on behavior management. And I did.
Good.
And because I think things that are so innate to us pediatric dentists that we do every day, from even our tell, show, do that is so just ingrained in us, but we're so good at it. We are so good in it that we don't even have to. And you're not. But you just told me about, hey, guess what? You could learn this really cool sort of late mixed dentition, class 2 correction that isn't, going to
axillary retractive, right?
There's so much knowledge to share. And I do think, tell me if I'm wrong here, that besides all of the practice stuff that we're talking about, no one wants, orthodontists don't want crying children in their practice.
Fact. Hard fact. It is a disruptor. It is. I had it. I had it. And I've said this on multiple episodes, and I was just on a guest on a podcast yesterday. It was recorded where it was a myofunctional therapist, and she's in Long Island. And we were talking about this thing of the behavior management. It came up. And I said, if it weren't for Fred Ferguson at Stony Brook, where I did my dental training, who trained us how to behaviorally manage children with special needs and adults with special needs. He put the dental students in with the residents who it was a special needs focused residency. We had to go in there and we couldn't sedate them. We had to figure out whether it was papoosing.
I did a special needs dental sort of like focus in dental school. This is our bread and butter. This is what we do. It doesn't even faze us. So for example,
but if you don't have that background, how do you even know? I mean, there's a lot of people out there who are an orthodontist like tell, show, do.
What does that even mean?
What do you tell, show, do?
I need to talk to them about what an explorer is before I go into their mouth. Like, what?
Right. I mean, truthfully.
This was the same conversation I had when I was advocating for the early age 1 visit when I would be talking to general dentists. If I gave a talk, the first thing that I would do is I would put on an audio of crying. And the whole audio, I just think it's like nails on a chalkboard times 1,000. You have to realize that they're expressing themselves. Right? They don't have the words. It's okay if kids cry. So for example, in my practice, which is also open bay, instead of crying being a disruptor, what it is showing other kids that if they're crying, that they're okay, that their parents are there. Like to me, a kid walking into a practice where somebody is crying behind closed doors, that's terrifying. You don't know what's going on. The imagination goes crazy. So in pediatric dentistry, the open bay comes from patient modeling. That because
they want to hold themselves to the standard of others or perform better.
Or if they see that somebody is crying, they also see that they're safe.
Yeah.
That nothing is really happening. Right. And kids are used to kids cry all the time as toddlers in preschool throughout the day in school. They see that they're okay, or they see that their parent is okay too. No one's freaking out. No one is freaking out about the crying. It's being handled. And then they see the child recover.
Yep.
And when they see that, it models for them. Or like you said, it's, I see that little 3-year-old sitting in there like a perfect little angel, and I got to get my act together a little bit. Like it's not.
Yep.
So
that's the one we use with open bays with the teenagers, because Joey's not going to want Susie 2 chairs down, who's in his biology class to see.
Like freaking out.
Right. As a 13-year-old boy that he's flipping out as he's got to be cool. You got to be cool. So those social pressures are appropriate, but we know how to manage those because that's what we're trained on. Right. We're trained, and it's just an easier population to work on if you don't know how to work on the littles. I find that once you know how to work on the younger kids, oh my gosh. But if you don't, it's torture for everybody, because you don't know how to, you don't know what types of cries they are. You don't know how to soothe. You don't know how to manage the parents coming. If you are in a typical orthodontic office and you are closed bay or open bay, but closed where the parents can't come in and out or see, and all of a sudden everyone's out in your reception room and they hear some kids screaming and crying, right? Parents are going to come in and be like, is that my kid? What's going on? I didn't think things were supposed to hurt here. It's a whole different shift of the mentality and the vibe of the practice. And you said it perfectly. Orthodontists don't want that in our offices. We don't know how to deal with it. It doesn't fit within our workflows. We'd have to completely,
real disruptor, like you said,
huge disruptor, right? And I'm saying this, granting them grace. Like I ran one of these practices.
They don't know what you don't know.
You don't know what you don't know. And we had to go through a lot of this, and we had ways to deal with it. And truthfully, honestly, Lauren, if I didn't know the impact I was having we also have to get them to believe that they're having a positive impact, because we're asking them to go through all this, and they've never also learned that it has any real purpose. So,
and bringing the child into these conversations about what is going to happen to them and why, and including them, I will tell you.
How do you do that? Can you tell me a little bit more about that? Give me just like an example of that for everybody.
Okay, when I do a consult, and I'm even talking about for a 3-year-old. All right, and let me just really quickly define this. This is sort of where my practice has landed with early treatment. Okay. I will start at 3, like when they get, now, I mean, we're doing myofunctional stuff leading up to 3. But let's face it, it's very hard, besides for nasal clearing, making sure they don't have attached tissues, talking about diet, all this stuff, to really be doing any structural growth guidance up to then. Okay. So
on that, just to quantify that, when you say at 3, you're try to ask this question the right way, so it is a logical sequence. In a pediatric dental office, you're seeing them still. So you're watching this patient grow, right? So you're able to kind of detect, okay, something's happening here. I'm guessing, correct me if I'm wrong, you're focusing a lot of it on nasal breathing, on more oral motor tone, on tethered tissues. You're kind of just...
And then when you start to get, when you start to understand what you're looking at more, like what a narrow palate looks like. I'm not even talking about a crossbite. What is the oral volume like? Okay.
And what are you looking for as ideal? What patients do you see at 3 and you say, nope, this kiddo's fine? What because not everyone's going to be perfect. So what sort of variations are you willing to tolerate?
So what I'll say is, and again, I'm a little bit lucky right now because parents are seeking this out, but I also have a hygienist that we start seeing from 0. So, these patients know they're in that kind of practice, but I'm not the kind of practice that's like everyone gets an expander at 3. Okay.
Okay. Yep.
The difference is, if I'm seeing sort of a growth, a future growth issue, and there's no symptoms, and what I mean by symptoms are, they're sleeping well, they're not mouth breathing, they're not snoring, they are feeling rested during the day, the mother or dad isn't talking about like these crazy sleepless night, all these things. I will say, I bet you that, we might find that there's going to be some crowding going on, that they might not have enough room for their tongue. And a great time to look at this is before 6. Let's do a workup around 5.5 and see what we have. Okay. For kids that are symptomatic, I want to start treating as soon as possible, because at the end of the day, this is what I was going to say. When I show up to work, what my goal is, and this sounds a little extreme, but it's to prevent irreversible brain damage. Period.
I know what you mean, but just for those who might be newer listeners to the show, or parents hearing that who might not know, can you just provide a little context to that?
Right. So it is complicated. Okay. But let's just say when your child is having unrestorative, restless sleep. Okay. So they're moving around a lot. They're changing positions. They are not getting into their full stages of deep sleep. And this deep sleep is where everything happens for a child in terms of building neural connections, consolidating the memory from what happened before. When we say rest and digest, we mean rest and digest. Your body is healing. If you're moving around all through the night, it's like you're still awake. You're not giving your chance a body to, and your brain, especially in the first 4 years of life, right? When the brain,
sympathetic overdrive.
Right. All day. And they're not, and there's some good research, even snoring. Snoring is not benign. Snoring has been shown, Gozal, a few other people have said, it has a neurological impact.
Even gasping during sleep has been found to, I think that was Isaiah and colleagues in Nature Communications 2021, has been shown to cause these neurocognitive deficits. Yeah.
Right. So, okay. That's what I mean by brain damage. And I don't say that to a parent, right? But we want these children to have an opportunity to basically grow as many healthy synapses as possible, to be able to get through their day, right? Equipped, feeling rested, and ready to learn. And when when you don't sleep well, even as an adult, we know how we feel. We feel like garbage. Kids don't even have, but we mask it. We know how to mask it. Now, we might be dying inside slowly, right?
Yep.
But we know how to mask it. My favorite saying as a pediatric dentist is like, when you see a kid, a 3 or 4-year-old just losing it, I look at the parent and I'm like, I feel like that maybe 5 times a day. I've just learned to not act it out. You know what I mean? Kids, they'll act it out. They'll act it out in school. They just don't have the emotional regulation. And, also knowing that sleep, lack of restorative sleep and ADHD symptoms are so overlapped that lack of regulation during the day can be really due to the fact that they haven't had a restorative restful night's sleep in days, weeks, and they can't use their rational brain to calm themselves down. Plus, kids don't know how to do that. They haven't learned that yet, right?
Right. And there are studies, because ADHD is a subjective analysis. Most use the Conners rating scale still. It's not like you take a blood test and have ADHD. So
the PSQ,
I was just going to say that they're both subjective diagnoses that rely on presenting symptoms and patient history. And when people in the orthodontic community will say, they say OSA because they don't think of the spectrum of sleep disordered breathing. They think of just end stage disease.
But that drives me crazy because
we'll come back to that
because it's so different.
It's so different. Trust me. Yeah. Oh my God. We could do 3 hours of this. Yeah. But on the OSA, actually, I'll want to come back to that part too on the OSA difference. But so let's just even call it. Let's say they know about sleep disordered breathing and the spectrum.
Right.
That, just because mouth breathing or sleep disordered breathing doesn't cause ADHD. It's not. Can you have ADHD without a sleep disorder? Yes. The problem is they both present in a very similar clinical presentation. And last time I checked, most pediatricians are not asking are not giving the parent a PSQ. They're not asking the child who has ADHD-like symptoms why that child is behaving that way. Now, they may ask like home life and all of that, but from a sleep perspective.
If they ask about sleep, what they ask is how many hours of sleep
hours a night.
Yeah.
Thank you.
Yeah,
they're not asking. Right.
10 hours of sleep. Was it garbage sleep?
Right. That's a great point. Are they easy to wake up? Well, those are irrelevant. That doesn't matter. They're not asking restless sleep and nocturnal enuresis and all of the, groggy in the morning, hard to get going in the morning, cranky throughout the day, behavioral problems, inattentive. So what do? They prescribe them speed. They put them on.
And they're already, like you said, in sympathetic overdrive.
Right. And so they have the paradoxical effect of the methamphetamine, essentially, they're giving them to regulate their behavior and not realizing that there was an etiology there that is sleep. So again, I to inject on that, but I wanted just to clarify that ADHD relationship there.
Guess what? If you have ADHD, it's only going to get better if you start sleeping better. I mean,
or worse if you're not. That's a great point.
Absolutely. People that absolutely do beautifully on medication has changed their lives. Okay. But you're going to feel even better. I never tell parents like, I'm going to get you off. And I'm just going to say, look, I mean, everybody feels more regulated when they sleep well.
Yep. Now, that being said, it's amazing how many did end up coming off. I agree with you. I never promised them or told them, but my gosh.
My son went off.
Yeah.
Yep. And my daughter didn't.
Isn't that interesting? Yeah, right. Which is why you don't promise it to people, because you just don't know.
Under promiser, over deliverer. I wasn't in the beginning because you get so excited, right? But what we are doing is one very important spoke of the whole wheel of wellness. And but what's so important about it is a time limited. What am I trying to say? Bonus isn't the right word. What I'm saying is that we are very important spoke in adult managing. But if we get them young enough, we're in a important way to help their structures grow ideally. And that's something you can't go back to unless you get surgery.
Mm-hmm. Yeah, no, completely.
Everything else is managing.
Yeah, right. You're treating the symptom versus this way, your approach and what we're talking about, treating the etiology. I
don't know what's going to, I don't think the longitudinal studies are out yet. They will be eventually about us who are doing this early work, what they look like in their 40s, 50s, 60s, right?
Right.
I don't ever say I am going to prevent your child from having sleep apnea. Right. What I'm saying is we're going to try to optimize their airway space, their function, work with collaborative providers that can help your child with that too, to basically give them the best scaffold that they can have going forward. We don't know what's going to happen with environmental I don't know, right? We don't know.
Absolutely, you don't know.
Trying to get them set up, for the best foundation of a house. And you don't maintain your house, even if it was built, it's going to fall apart. There's so many factors that go into this, but we're trying to give them the best scaffold and the best foundation. And unfortunately, there's a window of time that you can do that.
Yeah, I love the way you just phrased that. I really do. That's so well said. And I love that you're not overpromising, that you're essentially being realistic and honest with the parents and what to expect. And so now...
Okay, but then you have those miracle cases. And I do tell parents this. They come, they're a lot of desperate. And I will say, look, every once in a while, I'll do expansion. And it's like a miracle happens.
Yeah, literally. Understood. Yeah, it happens.
A miracle. And those are awesome. Most of the time, it gets better, but there's a lot of other things to unwind.
Yes, which is why the diagnostics are so important, which is why this whole thing that some people are like, oh, expand everything and it solves every airway problem.
No, it doesn't.
It doesn't. And our job is to look at the etiology. Why you could expand them as wide as you want, but if they have 100% obstruction of the adenoids and tonsils and rhinitis,
nasal cavity,
I was just going to say, allergic rhinitis and turbinate hypertrophy, it really doesn't matter how wide their maxilla and their mandibular arch are at that point.
They're not
you're just making it easier for them to get air through their mouth at that point. You're making them a better mouth breather, I guess we could call it that. So it's I say all the time,
teeth, but you're not addressing the health part.
Exactly. And I say all the time, the etiology is multifactorial. The solution has to be multifaceted. And then in a recent episode with Liz Walker, an orthodontic colleague, I told her I'm going to steal this from her, and oftentimes multidisciplinary. And I think if we can think of it that way, right, it is a complicated cause oftentimes. There's no one magic bullet that's going to solve it in every patient, right? That's why, like the Bhattacharjee study from 2010 about tonsils and adenoids, adenotonsillectomy only being successful long-term in 27% of patients. Why? Because the surgeon didn't know what they were doing? No, because like people in the orthodontic arena like to say, oh, well, expansion doesn't... Right. Expansion doesn't treat airway. There's
contributing factors of
other contributing factors completely. And so then this is a team approach. I mean, how did we start this conversation? Cheryl Weiss, who is not even in dental professional, she is in the speech and language pathology realm as an oral function. Right. You're working together with her. I know I've never spoken to you about this, but I can guarantee you have ENTs you work with. You have allergists you work with. You have other dental providers you work with. That also, though, Lauren, adds to the complexity of integrating this into a practice.
And we haven't even talked about the fact that a lot of these collaborative partners don't want to hear from you, or they're not there, or you're sort of in a desert.
Yes.
Right?
Do you face that a lot still, even though you're kind of known? I mean, you're in a smaller town, so you don't have a ton of options.
I do, but I found my people. Now, that often means that, and again, this is what I tell patients that travel a far way to see me. I am so grateful that you came here, and it's unfortunately or fortunately, I would say over 60% of my practice has to travel. And I'm saying travel more than 2 hours.
To see you, or travel to see a medical provider from you? Okay.
To see me. So it's definitely an access to care issue. I'm so happy that they're willing to do this, but it's not easy for them to do it. And then, I think, and this is also an access to care issue too, because there's a lot of parents that might know about this, but they might not have the ability to take off time of work or the finances to go to somebody else who's 3 hours away.
Yeah.
And it gets really, really hard. And that is a very, very hard part of the job. I have luckily found my people, and, a lot of times I'll just say, if they have somebody closer to them, I'll give them a try. Let's see what they say. Right. And if it doesn't work out, or if they're not interested in hearing it, come back and we'll I have a person, I have a guy, I have a girl, but trying to see how far we can get in different areas. And if it turns out well, I'm like, oh, what was that person's name? Right. So we can start
build the
that
network.
So I have people, but I wouldn't say if somebody's coming all the way from Plattsburgh, New York, which is a 3-hour drive, and my person is in outside of Boston.
Right.
Then
Right. Yeah, I know that was one thing Cheryl said is because I had some really good connections with an ENT who's now retired from practice and is in an admin role in a hospital, Jason Mouzakis, who's amazing.
Oh,
and
I refer to him.
You know Jason?
Yeah, I don't know him, but I used to refer to him.
Yeah. Jason was on the cleft craniofacial team with me, or we were on it together and at Albany Med. And that's how I got to know Jason. And Jason was the one that ended up having the surgeon, Shu Nadateo, on that team recruit me because I was sending him these patients. And this is where I just encourage people to develop these connections. I had heard he was really great and he was treating a lot of kids and parents loved him. So I literally just started sending him my CBCTs. This is back, I got a low dose CBCT in 2014. So I started sending him my CBCTs with pictures and stills and the whole CD. So they tell the story where he was looking at one of them one day and Shun, the surgeon, walked by and he's like, Shun, get over here. You got to see this. There's this Duluth guy in Schenectady and he's taking these images. Look at these amazing images. We got to get him for the cleft craniofacial team. And he and I developed this great relationship where I was so blessed and spoiled because he would send patients to me, right? Like I would get patients. They were a Dr. Mouzakis referral because he saw them. They're like, their adenoids aren't that obstructive. And, they don't really have much obstruction in the nasal passageways, but their arches are narrow and they're crowded. You got to go see Dr. DeLuke. And so I didn't realize how lucky I was because I had that relationship for a long time. And then I had an allergist who was my allergist and he was great with kiddos and he had his own private practice. He wasn't part of a big group. So it was it was just like I had my team and it was like, you're going to go see Dr. DeMasi or you're going to go see Dr. Mouzakis or both.
And that's the ideal. That's when you're really, truly living the dream.
Yeah. And I didn't know it. Right. I didn't know it. And then I get out and now I'm teaching this around the world. And one of the biggest questions I get, and I want to hear your answer, is
who are my people?
What do you do when you do meet that resistance? When you take all this time, all this energy, you and your team, you educate the parents, you help them understand why it's more than just the teeth, whether it be the decay from a pediatric dental standpoint or the straightening from an ortho standpoint. They are on board. They understand the need to go to auxiliary or additional medical or dental providers or myofunctional therapy. And you live in a community where you can't find them, or they go to them and it's very traditional, which is now sadly the story I was telling with Cheryl now in Albany. Now that Jason's not in clinical practice anymore, most of the NTs up there, they don't want to touch doing this on young kids. So what do we do? What is the solution?
So if I had the answer, I would.
You wouldn't be here talking to me.
Right. Okay. One of the things that I find that I don't do is and you can correct me or your listeners if you have a better idea, I'd love to hear it, is to not waste time in the moment of trying to change somebody's mind I haven't had good luck at making a personal phone call. Sometimes these people don't even call me back or I'll email about trying to say, this is the reason why I want you to do this. That might happen over time, right? But it's very difficult to talk somebody else's provider into doing something that's going to happen in the next month. Yeah. And I think it's sort of like banging your head against the wall. That's more of a long-term thing. I think, honestly, it comes down to, and this is where it's an access to care issue, is we may have somebody. They may have to travel. They may have to fly. And this is the problem. This is why there has to be more people doing it. And even in the time that I've been focused on this, which is just coming up to about 10 years, it's gotten better. I mean, there's so much more awareness. So I think it's, it's like not just doubling on itself, it's tripling, it's quadrupling in terms of knowledge. It's going to get better. But you're right. What do we do right now? Right. That, it's really, really hard. So you have to feel lucky if you even have a one person, right? Listening to you. And then you just, sometimes it's just a matter of sitting and tearing up sometimes with the same parents going, we are really in a pickle here. Yeah. What can we do? I would say that most parents that come to my practice are super motivated and they will find a way to get to where they need to go, but it's not easy and it's not fair because not everybody can do that.
Yeah,
so,
and I think, and I know you're going to have to run here, so I don't want to keep you long, but I have a guest coming on in the near future who came to see me speak. I gave a big talk at a study group in Atlanta a few weeks back, and he's a sleep physician, and he came to see me speak, and he's building an online portal with licensing. By the end of the year, he'll have it in 50 states where docs can go in and remotely upload records. Patients can even go in, and they deal with insurance. They go through the medical billing. It's a really comprehensive platform. He's going to come on the show and talk about it to improve that access to care, and then they will troubleshoot and let you know, at least get through the diagnostics and from people who understand this from an airway perspective. And then if you do need something, they will then seek out and try to help you find that provider to at least take out the whole struggle of parents going to this doctor and that doctor and this person and getting rejected and just demoralized. So I told him, I'm like, Avi, this is good. I mean, it's amazing. And he took me through the software a little bit too.
I'll listen to that. That'll be really good. And I just also want to talk too about what makes it worth it. I mean, first of all, working with kids.
That'd be a good thing to finish with. Yeah. I know we've been talking about the challenges here. Yeah.
But working with kids to me is it's always been rewarding. Even before I was in this space, it's just always so rewarding to take, a kid from here to there and to do it successfully in a way that makes them feel good about themselves and good about dentistry, right? That's just going to set them up for a healthier life. I mean, that always feels great. And that's one of the reasons why I think pediatric dentists do what we do, because there's a chance, it's like the new hope. There's so many things that we can do. Even if they had a mouthful of caries, it doesn't ever have to happen again. Right? Yeah. We can do these things, and that feels good. But I will tell you, some of the best connections or some of the best, I guess, serotonin or dopamine hits that I get in the day are the connections I have with parents that somebody is just listening to them. I haven't even done anything. I just listened and been like, you're not crazy.
Yeah.
You're really onto something.
Yeah.
You are really onto something, trusting your intuition and stuff. And they just cheer up, and they're so grateful that somebody is even acknowledging, even if you don't have the answer, just acknowledging what they're going through. And, for anyone that's in healthcare, we got into healthcare for those kind of relationships, and they're really powerful. And those are the ones that when you're in the middle of it, I have crazy days. I have crazy days where I want to sneak out the back. We all do, right? Mm-hmm. But when you have those interchanges in between, it brings you back and makes it all worth it.
Yeah.
Right. No, and it's so rewarding. And
that's your why.
And it keeps you fighting. It keeps you in the game, because we all have bad days. We all have days when everyone is, saying no, no, no. And like, why am I still in this fight? It's so hard because you have those kind of interactions. Yeah. And, we didn't get a chance to talk this, but when you said about talking with kids, I would encourage, kids are smarter about their bodies than we think they are. And I always start my consult with talking directly to the child. Yep. You don't even look at the parent, and asking them questions, age specific, but you won't believe how many kids you can ask at 3 or 4 and say, how do you think you slept? How do you feel? Bad. Really? Tell me a little bit more. Describe it to me. And they know so much more than we think. Sometimes they know more about themselves than their parents do.
Yeah.
So I would really encourage finding a way to start, when you start, get all your records, all that stuff. But when you sit down and talk, to engage the child, because you also have to get them on your side. Because like we said, this is a journey. It's not like you're just wearing anything you put in your mouth, even a clear aligner, feels weird. We are asking them to do something that's going to take a long time. They need to know why, too. They need to have a motivation other than just because their dentist and their parents said so. Right. And so you have to get to what it is that's making, and sometimes it's just, would you like to feel better when you wake up? Yes. Yeah. Okay. This is going to help you with that.
Yeah. Yeah, I'm so glad you said that, because I hear all the time from people, I can't get, my 5-year-old to take Tylenol or Advil or whatever, and they have a high fever. That's their justification for not treating kids younger. Well, that might be a you issue more than the child issue.
And in parenting, we're so frantic and stuff. Instead of just saying, take the Tylenol, sitting down and be like, what is it about the Tylenol that you don't like? And that's what I tell kids too, going forward, is I want to hear from you. Right. Please speak up. And I'll say, half the time, it might be so easy if you tell me what's going on to fix something so it's not bothering you. The other half of the time, it might be one of those things, Johnny, that I'm just going to have to tell you, you're going to have to kind of grin and bear it for a second. But always speak up, because sometimes there's a really easy solution, right? So even like, why isn't your kid taking the Tylenol? Why? It could be a texture issue. It could be a taste issue.
Right. Flavor issue completely. Right. A myriad of reasons. Right.
And then you open up, well, what could we do instead?
Right. Maybe we put it in a little yogurt, right? I mean, it's like, here, let me stuff this medicine down your throat, and versus let me shove these expanders in your mouth. Well, of course it's not going to work. So, well, listen, I know you got to run. What a fun discussion.
Yeah,
that was great. I appreciate your honesty, your candor, your passion, your dedication to this. I know you're fighting a lot of fights to try to continue to do this, not just within a practice, but in a community and within the greater dental community as a whole. So I thank you for your efforts on this. Glad that you got... Thank you. We've got to stay together as a team to keep getting this message out. And I'm proud and happy to do it. And I'm happy for the journey you took, that you started, had that ortho exposure. Things happen for a reason, right? I mean, you're training in Maryland and then working in that practice where there was an orthodontist, and then seeing it and then going up to where your dad and your uncle were. And now look what you're doing. I mean, just those little things. Now you're just changing so many lives.
And I can't imagine doing it any other way now.
What's your calling? It's your calling. So keep it up. It's an absolute pleasure, and stay in touch. And I really appreciate the conversation.
Thank you. Let me know about let me know about what you have coming up too.
Oh, I will. Yeah, no, I'll make sure I let you know about it. So,
okay.
All right. Appreciate you
so much.
Thanks.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.